The University of Tennessee Medical Center is our region's only academic medical center. Our mission is to serve through healing, education, and discovery. Our goal is to share the knowledge of our physicians and staff in these health education videos as you make healthcare decisions for yourself and your family.
The screening guidelines for colon cancer are based on a collection of advice from both national and international societies that have evaluated this topic extensively. The most common recommendation is a colonoscopy beginning at the age of 50 and repeated no less frequency than every 10 years. Alternatives to a colonoscopy would include a fecal occult blood test, which means we check the stool at least annually for blood in the stool. If that's positive, we'd recommend a follow-up colonoscopy. Other alternatives would include a flexible sigmoidoscopy, which requires evaluating the colon just on the left side and can be done every 3 years, in addition, in conjunction with a fecal occult blood test. There's some newer technology that has not been fully evaluated or recommended, but a CT imaging of the colon, or CT colonoscopy, where a barium enema would be given and then a CT scan would be done to follow. These recommendations all begin at the age of 50 unless you have a family member that has been diagnosed with a colon cancer before the age of 50. So for example, if you had a brother, father, mother, or even sometimes cousins or first and second degree relatives that were diagnosed, let's say at the age of 47, we'd recommend that your screening starts at the age of 37. If something was found on fecal occult blood test, we would recommend following up on a colonoscopy. If something was found on colonoscopy, it would depend what was found. If it appears to be a small or benign polyp, the endoscopist, whether it's a gastroenterologist or a surgeon, would do everything possible to remove it endoscopically, and often that removal is curative. If the biopsies come back consistent with a cancer, the best chance for cure is a surgery, and often a referral to a surgeon is then commenced, and the discussion would be based on what type of surgery would be performed, whether an open surgery or a laparoscopic surgery, based on the location and the type of tumor. If a non-polyp or a cancer was found, examples would be an inflamed colon, such as ulcerative colitis, or other inflammatory conditions, possibly even infectious related. Often a referral is to a gastroenterologist for further management. Treatment options for colon cancer depend both on the size of the tumor as well as the location. For the right, middle, and left colon, the first options are surgery, if at all possible. If there's evidence that the tumor has traveled to other organs, such as the liver, often we'll discuss with a medical oncologist whether or not upfront chemotherapy is best delivered first versus surgery. The surgery can be performed as a partial or total colectomy and can be done either laparoscopically or in an open fashion. If the tumor is found in the rectum, nowadays we often recommend that the chemotherapy and radiation is given first, as the local recurrence or the chance of it coming back in the rectum is significantly reduced if that process is started first, and then surgery is commenced approximately 6 to 8 weeks after the chemotherapy and radiation has been given. Fortunately, a colostomy is rarely needed as part of routine colon cancer treatment. For most of the actual colon itself, the right, middle, or left colon, surgery is typically performed in an elective fashion where the bowel can be given a bowel preparation or cleaned of any stool, and a primary anastomosis or sewing the bowels together is the typical procedure. If the colon is completely obstructed or the colon has ruptured, often a temporary colostomy is performed to ensure that no infectious complications are performed. For rectal cancer, the decision for a colostomy is often based on the location in the rectum. The closer the cancer is to the anus, the higher chance of a perforation or a leak after surgery. So often within 5 centimeters of the anus, a temporary colostomy is recommended. It is extremely rare nowadays that a permanent colostomy is needed, though if the cancer is exactly at the anus where no margin can be taken, rarely a permanent colostomy is needed. There are recommendations for a lifestyle that can be healthy for the colon. The first would be a recommendation about your diet, and the first recommendation is based on high fatty food, specifically a diet with high portions of red meat. The theory is based on comparing societies that eat a large portion of red meat versus those that don't, and those with decreased red meat portions have a lower incidence of colon cancer. Again, that's a theory. The second is related to those with a higher incidence of constipation. It seems that the more constipated a patient is, that the higher incidence of colon cancer. Therefore, the recommendation is for increased exercise and a high fiber diet, which both work together to decrease constipation.
We hope you'll join us soon for another medical moment. Visit utmedicalcenter.org or call the Healthcare Coordination Office at 865-305-6970 to learn about services available at the University of Tennessee Medical Center.